Good morning. I'm Niv Ad from White Oak Medical Center at the University of Maryland. And today we have an expert panel here that's going to discuss the importance of atrial fibrillation in decision-making in structural heart disease and coronary artery disease. Let's first introduce the panel. We'll start with Joanna.
So my name is Jo Chikwi. I'm at Cedars-Sinai in Los Angeles.
I'm Vino Thorani, cardiac surgeon at Piedmont Heart Institute in Atlanta, Georgia.
And I'm Mark Gertish at Franciscan Heart Center in Indianapolis.
So we had a couple of very exciting days, and yesterday we had a very interesting session on TAVR in general and the quality of the trials that were done and what they contribute to us. But Vino, when it comes to aortic stenosis and the patient do have an established AFib, let's say persistent and long-standing persistent, what do you think in the heart team environment, what should we talk about when we make a decision whether patient should have SAVR or TAVR, and what type of intervention for the atrial fibrillation? Appendage only, MACE procedure, anything in between?
So I think that's a great question, Niv, and we've been talking about this more and more for the last, I think, 1 to 2 years. And I think if we break the patients down into high risk or extreme risk patients, I think a lot of those patients are going to transcatheter valve therapies, and we're just dealing with their atrial fibrillation with anticoagulants or some type of medication. So they're not being treated terribly well with open surgery because a lot of those are going straight to transcatheter valve therapies. Now, as we get into intermediate risk and lower risk patients, I think that conversation is becoming more prevalent and more robust, especially in the low risk patients. As you know, in 2019, low risk patients were approved for FDA tri-leaflet valve patients. I think what becomes important is if you have a 65-year-old, 66-year-old who has atrial fibrillation, now in the heart team, we actually discuss with them transcatheter valve therapies versus having atrial fibrillation, MACE operations at the same time as aortic valve replacement. So that conversation is really taking place. Unfortunately, all 4 of us know this, there's no good data on it. There are no randomized trials. We all know that having atrial fibrillation continued for years actually decreases your survivability. So I think that discussion, it should become more robust. It should become more heart team oriented. Patients should really be informed of the good things and the bad things about having atrial fibrillation. And I think that potentially I'd love to see a randomized trial. I've been talking to the companies about doing a randomized trial in this, SAVR, TAVR versus, SAVR plus MACE versus TAVR and either a Watchman or something like that. So wide open field, really, really interesting for me to think about.
I completely agree. And yesterday we had a paper from Northwestern that was presented, and it was shown that even if the patient is getting to surgery according to the STS database, and this is recent, 2014, 2017, only 30% of them are getting treated at the time of surgery for any AF ablation, let alone ablation that is designed to address the type of atrial fibrillation. So what do you think about penetration of surgery when the patient do come to surgery? Is it important? Why surgeons are not doing it?
So I think how Vino's outlined the knowledge gaps is really on point, and the randomized trials that have already been conducted in the SAVR-TAVR arena certainly give you a platform of data that you could amalgate and query that could probably inform the design of a prospective study to look at how you make decisions in these patients. In terms of the practice variation, it's huge. When we look at registries, we can see a huge variation. It's very notable in the mitral space. It's also in the aortic space, so that patients that come with paroxysmal permanent atrial fibrillation for surgery, depending on the surgeon, have got either a very minimal or a very high chance of getting a concomitant ablation procedure plus or minus an LE closure. So there's clearly a lack of knowledge and a lack of consensus, and we need better data to inform our practice. I suspect that one of the drivers in practice is that it's very difficult to do a MACE procedure through a right anterior mini thoracotomy or a right and upper hemistenotomy, and that's what surgeons are increasingly being driven to offer as sort of way of offering a patient a minimally invasive surgical procedure to compete with TAVR. So I think advocating very, very strongly for an aggressive approach to atrial fibrillation treatment is key. It's relatively easy to close the atrial appendage, and I think the use of and the dissemination of devices has really hopefully improved our ability to do that minimally invasively.
When you also say, Joanne, that it's not for concomitant procedures, not only is AFib, the idea of even doing anything is heterogeneous, but also the type, what you would do. Would you open the left atrium and do a left-sided maze versus just doing a pulmonary vein isolation? I have people who do, for persistent, do a left pulmonary vein isolation. They say, great, I've done your maze. We all know that that's really not very beneficial to them.
I think this is a valid point that requires, another maybe roundtable discussion just on that surgeons tend to package AFib as one entity. And as you alluded to, it's not. It's different. And this is why the variability is not only in the penetration of actually doing a procedure, but also in what you do. And then going back to that STS paper from yesterday, so 70% of patients never treated with an ablation, 30% were treated with an ablation. But when you look also at other low-hanging fruit, which is almost a no-brainer, only 58% of the patients that had the ablation had their appendage excluded or excised, and only 16%, 1/6, of the patients that didn't have treatment had their appendage treated. Mark, what do you think about it?
Well, first I have to go back to what we do know as far as data goes, because people talk about, okay, we're going to do a randomized control study comparing AVR, TAVR, AVR with a maze, or some type of AFib therapy. What we do know is that when we look at the TAVR populations, this has been published, that the patients who have either new onset AFib or pre-existing AFib don't do as well as the patients who didn't have AFib before their TAVR. And the focus was on the new onset AFib because it was fairly dramatic, and maybe that's because we uncover AFib that existed before. But the point is that AFib was a negative prognostic factor for how long they would live. And we know in the surgical data that if a person has their AFib addressed, or if let's look at large population numbers, if people have their AFib addressed at the time of surgery, they're more likely to be alive soon and late after surgery. And then in focus centers of excellence, we see over and over again that the addition to intervention for their atrial fibrillation leads to better survival and outcomes. So we actually know that, and the likelihood that we're going to get a randomized control study to ferret this stuff out is pretty unlikely. And when we talk about minimally invasive, yes, we all do minimally invasive surgery, but to think that we're going to get the whole nation to do minimally invasive surgery when we can't get them to actually even do a fib intervention, I think is a pretty dramatic idea. Like you said, patients who have atrial fibrillation that's going untreated in the operating room, only a small percentage of those even have their appendage closed. And we know the appendage is the primary mechanism for stroke. So it's, it starts with education, the people being trained and finished. Only about 70% or more than 70% feel they can't do AFib surgery when they finish. And then it moves on to kind of complacency and motivation, and how do we get people to look at this as a disorder that we treat over time, which surgeons don't really invest themselves in for long-term care.
But Mark, to that point though, we continue at all the national meetings. We have separate AFib meetings. How do we get people to do this more? I mean, is it, we publish on it. I mean, what is the way for us to teach people to do more? I'm still struggling with that because we talk a lot about it. We all know, and we've seen data, not always randomized data, but we've seen data showing the benefit of doing something. How do we get past that hurdle? Because I'm struggling with that, and I'm curious on what you guys think.
I think just to answer you, and then I think quickly, I think this is an excellent point. And there is education piece, but it's also the way we look at results. And it's going to be maybe a nice transition to the next topic in a moment for CABG. So if we go to the operating room today and do a CABG without a lima, it's being basically reported as the quality of the procedure is less good. We need to work in a sense that the quality of the surgery should be defined. If you have CABG and aortic stenosis, if you didn't address the appendage and you didn't address the AFib, and I'm not talking what to do because this is an argument, which will never end.
Put it in metrics.
We put it in metrics, and I think this way we are going to elevate the awareness and also maybe push a surgeon into doing the reasonable things. We're not asking not to do reasonable things. If you cannot do the appendage, say why you didn't do it.
So we just had the exact same discussion in the coronary arena. How do we increase utilization of a multi-arterial strategy when there's a real emerging consensus it's beneficial and yet maybe used in less than 10% of appropriate patients in the US with huge practice variation by individual surgeons from 0 to about 100%. It's a three-pronged approach, and it's the same with mitral repair, trying to improve repair rates. You have to educate. If surgeons are graduating without facility and understanding of the benefits, then it'll be very difficult to help them apply that in practice. 2, you have to educate your cardiology colleagues because referral practices drive cardiac surgical practices. If you're getting patients because you're doing a multi-arterial revascularization, that increases the chances that you're going to do it more appropriately. And then thirdly, it's exactly what you say. It's how we use our metrics to drive better practice and greater quality.
Yeah, I completely agree. So let's talk about a little bit about coronary bypass surgery and AFib. You know, the stunning data is, which is really for us, I think it's also stunning, that most of the patients with AFib that we see in our lifetime are actually CABG patients, because 6 to 8%, according to the STS database, are patients with history of atrial fibrillation coming to CABG. That's the majority of the patient still. And yet, if you look at different databases, the penetration of surgical ablation for atrial fibrillation is anywhere between 15 to 30%, depends which database you look at. Same grim situation as we have with aortic stenosis. So let me just throw into there like a very provocative topic. So when we look into a patient, what is more important, total arterial revascularization or CABG and AFib surgery when we look at 10-year survival, based on the data we have today?
I'm glad Joanne's going to answer this one.
Well, I think we all know there's no multiple randomized controlled trial that shows a benefit with arterial grafts. Registries show probably confirmatory bias, but you know the survival difference is there. It's
What's the
arguable.
survival difference?
Well, for multi-arterial revascularization, it's sort of the order of 17 versus 20% absolute, so 3% survival difference at about 10 years, and obviously it's much more profound for atrial fibrillation. Atrial fibrillation really decreases your life expectancy, is why we're here talking about it. So I think that's a very fascinating perspective that you're bringing to the discussion. Where should we be focusing? I would argue it is not about picking one. It is about the quality of what we do as cardiac surgeons. It is about delivering a tailored, individualized approach that's appropriate for the patient in front of you. And that may involve a multi-arterial strategy, and it may involve correcting atrial fibrillation, and it may involve a considered approach to other structural issues and the management of the patient. But it's excellence and quality. It's not one or the other.
I agree.
I would even posit something more controversial, which is, indeed, we would like to see everyone doing a lot of all arterial revascularization. We'll hopefully see some progress in that. The likelihood that we're going to see a major conversion, I think, is relatively small, to be honest. But if we were to look at coronary bypass surgery and we were to leave out the circumflex distribution, in other words, ignore it in the operation, versus adding a surgical complete maze procedure, clearly, in my mind at least, remains to be proven, but clearly there would be more benefit in eliminating the atrial fibrillation, treating the atrial fibrillation than ignoring the circumflex distribution. And you know, we talk about Lima to LAD. You know, we all adopted that because it was a kind of an easy thing to do that we knew had huge impact. When you move over to all arterial revascularization, when you move over to aggressive AFib therapy, it becomes less easy and more complicated for these people, for people performing the surgeries. So it's a matter of facility versus adoption, and that is the challenge that we face.
So, you know, and Niv, you know the data, you and Mark know the data on CABG and AFib extremely well. Why not do a randomized trial? If we're having problems convincing everybody, right? One of the reasons, let's be honest, that TAVR has taken over in the last 10 years. We've done 7 randomized trials with 8,000 patients have been randomized. And because of true randomized trials, you can criticize the randomized trials, little nuances here and there. Let's just be honest. Nowhere else before have we done 8,000 patients in randomized trials, prospectively followed for 5 years, and now we have completely changed the pathway of how we treat aortic stenosis. I think that it becomes incumbent on us if we're going to show prospective match or retrospective single center areas. I think it's incumbent, if we're this passionate about it, we need to do randomized trials to prove this, follow these patients for 5 years, and get something really on paper that will change it. That, I think, is the way we change as surgeons. We haven't been great about randomized trials. I think we have to push ourselves into that pathway.
Yeah, I completely agree. But there are a few challenges. And one of the challenges we have in general in cardiac surgery randomized trial is that, without being too politically correct, is there lack of interest from the industry to invest in cardiac surgery. So who is going to pay for those trials? I
don't disagree. I don't disagree with that at all, and that's not politically incorrect. I think you're absolutely spot on for that.
Yeah. So I think that's the biggest challenge we have. The second challenge we have is, the ones that listen to me talking and Mark about this topic quite often in the past few years, looking at atrial fibrillation as a surgery as a singular outcome is wrong. It's a multifaceted outcome with drug usage, anticoagulation, especially in the elderly, thromboembolic events, quality of life, and longevity. And so the design of such a trial is going to be awfully complex, and the number of patients that we will need is going to be significant. So I think we need to move towards it. I mean, and I agree with you about your statement about the aortic stenosis. I mean, this is actually what we learned from those trials is amazing. I mean, it's something we never learned about the quality of the surgery, which is great, as the new technology, which is a very huge, it's a significant change to us. So I think we need to go there and try to explore it with some interest bodies.
No, absolutely. It may be different adaptive type of trial designs, but we need to start thinking about how do we move that. We're all talking about how do we move the needle.
Yeah.
And the only way that I've found in the last 15 years to move needles is to do really good science and less retrospective, sometimes biased trials from single institutions.
No, I completely agree.
So the CTS Trials Network is a phenomenal platform for exactly that kind of study. I think they're midway through enrolling a atrial fibrillation trial in the mitral area. And again, I think you've absolutely underlined the need for more robust data to really inform our practice.
Yeah, we have a few more minutes, and I want to kind of shift the focus on something that's technically easy and almost a no-brainer, and that's the management of the atrial appendage. Everybody's talking about the Watchman, about the Emulate, but the device that is being used the most by a huge margin is the Atri clip, and it's a commercial name, but it's a clip that's being applied, different designs, but same concept. And Mark is involved in some degree in a way of prophylaxis, even clip placement in a randomized controlled trial. And I would like just a couple of points about the clip. First, maybe Mark will tell us what's been done and where the data is right now, and then talk a little bit about the cost and reimbursement of the clip, which is a huge challenge for most of us, if not all of us.
So sure that, sorry. Those are great points, and indeed, so many patients who have atrial fibrillation aren't having their appendage managed, let alone the notion of obviously prophylactic management of the appendage. But we did do an early primary study, 2-to-1 randomization in prophylactic use of the clip, 2-year follow-up showing a statistically significant lower incidence of thromboembolic events for those patients in whom we closed the appendage prophylactically. In other words, they didn't have a history of atrial fibrillation. If you look at Framingham data, we know that people who have cardiovascular disease, 50% of them are going to develop atrial fibrillation in their life. Everybody we operate on has cardiovascular disease. All of those patients are at risk for it. And then we also recognize that people who have heart surgery have a higher incidence of perioperative, and that extends out for months after the procedure. And I would even say that when we saw the Danish data that said that we should anticoagulate everybody who has an aortic valve replacement with a tissue valve, I would say that maybe the signal there wasn't related to the valve, but was related to perioperative atrial fibrillation, which clearly has some incidence of stroke related to the atrial fibrillation that goes on beyond the hospitalization. So we also are in the process now of extending that 2-to-1 randomization to a larger study. And meanwhile, we have in our own center several hundred patients who've had prophylactic clips, and we're in the process of completing that prospective evaluation of the data that will have something to offer. But the device is so fast and easy to apply. The risks related to it are extremely small. People are concerned about inflammation, fibrosis around the clip, and having reoperated people who've had the clip, it is very fibrotic in there. But we have no data to support, or no one has offered data to support that it compromises grafts, or there's other complications related to that. So the expense is the expense, and relative to anything else that closes an appendage, it's extremely inexpensive, except for suture. But we can't close the appendage well with suture. We've shown that already.
So I would take a slight issue with that. I think the device is phenomenal. It's very easy to apply, and if it increases the rate of appendage closure in patients, generally fantastic. At CTSNet, we do 95% of our mitrals robotically, mini thoracotomy, and we obviously don't use a clip in that scenario. We routinely close every single atrial appendage with a double layer of suture line, and my bias if I'm doing a coronary is I excise that appendage and I oversew it, and that isn't going to reopen.
So I think it's true if you excise it at the base and sew it shut. As you know, in ALLOW studies, repeatedly it's been demonstrated that surgeons don't do a great job of closing the appendage.
I think that you're absolutely right, and a purse string single layer closure is not the way to close the appendage.
Yeah, or a running suture from the inside. And the only way we would prove that would be to do CT angiography on those patients and do a comparative study. We always think that we do things so well, but if we take a really close look, sometimes we find that there's a failure. And going through the transverse sinus with a clip is a very easy thing to do robotically or through a minimally invasive incision, which is what we do for all our mini.
So I'm enjoying this, Joy, and I'm going to give it back to you. Keep going. Niv and I are enjoying this interaction.
So I just, we changed our practice for the right mini thoracotomy, and we published, and it was based on actually testing our own results. So we are all excellent surgeons until we really look into our results and see that they are excellent, but not as good as we thought.
I think that's a great challenge, and you've just given me a wonderful idea for a study.
So
thank you.
6 months after surgery, when we tested our 2 layers closure, we had about 6% recanalization. And this prompted me to start the transverse sinus approach with the clip, which is with many patients and disseminated worldwide now. And I think that's a really valid, easy option for minimally invasive mitral valve procedure. The cost is outstanding, and that's the problem. That's where I am having huge issue with the technique.
I've actually have given away on the sutures, and I've gone straight to the clip too. So I have made that change over the last 5 to 7 years, and the cost is the cost. I agree with Mark.
So one last thing I would comment on the notion of cost. First of all, we know that there are other practices in cardiovascular disease management that spend a lot more money than we do on any given procedure. Yeah. But just setting that aside, when we move toward minimally invasive and faster, more efficient operations, we also find ourselves sending everybody home instead of to an extended care facility. And there are thousands and thousands of dollars that we save by doing so. Oh, yeah. So if it fits in the context of minimizing trauma, providing a more comfortable, more rapid recovery, and avoiding $15,000 in post-acute care, that translates into a win for the patients and for us.
But Mark, let's just be careful there. Just because you clip somebody's left atrial appendage doesn't mean that they're not going to go to home health now. Let's just be, or an LTAC. Let's just be honest.
Makes minimally invasive surgery easier. That would be my point.
Yeah, it's much easier. It saves time and so on and so forth. Sure. So unfortunately, we are kind of at the edge of our time limit. I'm sure you all got the sense that there is more to discuss and more studies to design, but the take-home message is that the appendage is important, whether you believe in atrial fibrillation ablation or not. It's an easy way to do it. And it's there, so why won't you do it? And for the other questions, we need to keep working on good design, large trials with long-term follow-up so we can have more information. Thank you all for coming, and see you next time.